right, let's get started. Good evening, afternoon, everyone. Thank you all so much for being here. I am J'Leise Sosa. I'm an OBGYN and medical director of Oshai Children's Hospital OBGYN Center. Say that 20 times fast. We are so grateful and thankful for you for being here. This event was born from the women I see every day in my office, and some of you are here. Women who trust me with their most vulnerable moments, the things that you don't often share with anyone else. I've listened to your stories, your fears, your frustrations, but I've also seen your strength. What you continue to accomplish despite challenges with your health, despite pain, and sometimes despite the systems around us that do not pay attention to us is remarkable. And it is you, these women, who inspired this idea. This event started because of you. I'm deeply grateful. Thank you all. I'm deeply grateful to the people who believed in this vision from the very beginning. To Shannon Bryant, our Chief Diversity and Equity Officer at Kaleida Health, thank you. Jessica Zaskruski, our Vice President of Women's Health at Kaleida Health, thank you. Dr. Dory Marshall, who isn't here, our Chief Medical Officer at Oshai Children's Hospital. You didn't just listen, but you helped shape what this is today. I appreciate you. To Dr. Gail Burstein, our Erie County Commissioner of Health, did I say that right? Who the day I cornered her at this press conference and said, "Hi, I want to talk about women's health in Erie County, help." And within a week, she was able to have a meeting with Karen King, who is our commissioner for the status of women. We sat down, we talked about how we could make this happen, and she just got her network going. There were emails, and all of a sudden we were having weekly meetings. She was like, "We need to invite this person, that person, this person would be great." And thank you so much for not even questioning me. You said, "Okay," and you ran with it. I appreciate that. Thank you. To Dr. Jean Wendy, the Dean of the University of Buffalo Department of Public Health, thank you too. At some point, we'll have you appear on the panel because Dr. Wendy is an expert in all research related to women's health too. She's our local expert. We have so much expertise here in Buffalo that we need to tap into more. But thank you too for your conversations, for thinking ahead of what else we could do and what more, how much more we could get research and action to occur in tandem. I appreciate you. Kelly Marie Wofford, you were a gem. Kelly is the director of the Office of Health Equity at the Erie County Department of Health and a panelist today. Thank you for always keeping the most vulnerable at the center of the conversation, letting us always realize that this is who we are here for, and it is important that when we keep the community at the center that we actually are doing the best for everyone. I appreciate you. Dr. Joshna Singh, our panelist, who also, we said, "Hi, we have this thing going on and we would like to be a part of it." She's like, "Yes, when? Tell me, I'll be there." I have known Dr. Singh from the maternal health side of things. I send my patients to her, and we always get such amazing reviews of your thoughtfulness. And it's really important, too, that we have specialists outside of obstetrics and gynecology who realize the importance and the uniqueness of things related to women's health. And we thank you so much for your partnership today. And Dr. Sarah Berga, the chair of the University of Buffalo Department of Obstetrics and Gynecology, and many other titles, and expert reproductive endocrinologist. Thank you for being a leader in women's health at all levels, from the university, community, for being an excellent teacher. And I just have to say I'm so excited that there's so many women in leadership and making change in our community that I look up to and I value, and thank you so much for your support here. And we just want to acknowledge that today, October 18th, is Menopause Awareness Day. And so it's quite significant that this event is starting today and we're starting this conversation today. And I hope you heard we said we're starting the conversation. Today is not a one and done. We want to keep this going. So tell your friends, tell your sisters, tell your moms, tell the men in your lives because they support you too. And listen out for when we have other events and be there. Okay? This event, like I said, is a collaborative event, and we are thankful to the Erie County, University of Buffalo, Kaleida Health, University UBMD, so many of the departments, Catholic Health, Oshai Children's Hospital, the Office on the Status of Women. And I have to especially thank other organizations who, when they heard about the event, supported in other ways. I have to thank my sister physicians of the Healing with Her podcast. Dr. Rush and Dr. Rita are here. This is also a plug to go listen to our podcast on YouTube, Healing with Her podcast. To the Buffalo Urban League, to United Way, Women United. Misty, thank you so much for being here and for your support. To Roswell Park. Roswell Park donated some of the books that were given away today, so thank you to them, and especially to Crystal Rodriguez-Dabney, who did that, to our Maston District Councilwoman, Senator Everhart, and to our Assemblywoman, Majority Leader Crystal Stokes, who both supported and shared our event with the community. We appreciate you all. All right. So let's get started. Today's event really is a conversation. We don't want to speak at you or to you. We want you to drive the conversation. No question asked is too silly. There's nothing such as a stupid question. If you're brave enough to just stand up and speak, go right ahead. If you prefer to write your question down, do that. We'll collect them and we'll bring it to the panel. All right? But how about we start with the general idea. Let's define what this time is. The point of this conversation is to discuss what happens after childbirth, which, you know, most of us probably aren't having kids 35 onwards. What happens to our ovaries after that, Dr. Berga? What is ovarian aging?
Okay, so we didn't practice ahead of time. What is ovarian aging? Actually, we like to talk about the lifespan of the ovary. And there are a lot of people trying to get pregnant after 35, and it gets harder. And people know that, and that overlaps with this transition period that we sometimes call perimenopause, but it has lots of other names as well. And so it's been poorly understood. Lots of studies have been done, but it's a time of great, I would say, change is like, you know, the word that always gets used, but it's an unpredictable change. Like, it's not something you know is going to happen, and sometimes it catches you unaware. So then you go into menopause, where the water is in some ways still again, but for 15 years, from like 35 to 50 or 40 to 55, people have hormonal fluctuations that cause all sorts of symptoms, and often not actually understood to be related to the hormonal changes. So I like to say this because it just destigmatizes it a bit, but a common complaint is joint pain. And you may not end up in front of an OBGYN for joint pain, right? That wouldn't be your first impulse. So a lot of the symptoms are so variable that you might end up in a physician's office or a provider's office, and they're really not thinking that this is anything related to your hormones. So part of the education journey is to realize that hormones affect every part of your body, not just your fertility. And that's, I think, why J'Leise wanted to bring this to the forefront, because otherwise it just gets tabled or unheard.
Dr. Berger, I brought this a lovely...
I can't see out of the back of my head yet.
As a reproductive endocrinologist, this is Dr. Berger's wheelhouse here.
Thank you. We were told no slides, but I mean, I do want to say something, though. We learned to measure hormones in the 70s. So it took a long time to get this information. So the cartoons that we sometimes carry in our head are that there's a little dial on us and the hormones turn down. Actually, that's not what the studies show. It's just weird, but the hormones turn up and then they turn down. And so sometimes there are hormone crashes, sort of like baby blues. And those hormone crashes send women in to see people, sometimes the OBGYN, but sometimes someone else. And I feel like that story, which I remember reading this paper by a colleague of mine, and it was 96 when she sent the paper in, and I'm reading it. And I know her. We trained together. It's a brilliant paper. And I am still quoting it to this day, but she showed in women from 35 to 50 that the estradiol levels, that's the hormone the ovary makes, that's an estrogen, were going up. And no one anticipated that. And then the progesterone levels, which protect the lining of the uterus from overgrowth, were going down. So people have fibroids growing, new onset migraines, heavy periods. That's the gynecologic side, but the joint pain no one really anticipated, even though it's a really big complaint. So all of a sudden, people are like dealing with, I think, unpredictability at a stage in life when you've got teenagers. So one of my patients came in who was a IVF mother, and she said to me, Dr. Berga, you forgot to tell me. I'm like, uh-oh, what now? She says, my daughter is going through puberty when I'm going through menopause. Is this fair? I was like, but it's not unique to your IVF pregnancy. I'm not sure it's fair.
All right. We have a question. This person turned 65 this year and is experiencing body pain, stiffness. Any suggestions on what to do?
So there's been like, does anyone know what a Post-it note is? Okay, so this is a poor person that invented a glue that didn't work, and he almost got fired. But then he made Post-it notes. It turns out that you can embed in that glue estradiol, the ovary's favorite hormone, and you can post it on yourself. And it actually can be used. There's a lot of recipes. I'm not going to really have time to talk about them, but I feel like what happened to that idea, right? So these came out in the mid 80s, and around that time I was learning to do IVF. We were inventing IVF. I mean, no one was teaching us, we were figuring it out. In vitro fertilization. So to make the lining ready for implantation, we would never have used anything other than estradiol, which is what the ovary makes. And people were saying, well, after menopause, you don't have to use estradiol. You could just give anything. I thought, okay, so we didn't want to use it for fertility, but it's okay for older women. This doesn't make any sense to me. So a lot of work got done. And I think what didn't get done is an understanding that all estrogens aren't the same. When I tell people all women aren't the same, I never get any pushback. But when I say all estrogens aren't the same, it's fighting words for some folk. And that is still, I think, a concept that is lost oftentimes in the medical profession. So everybody doesn't need the same dose, and everybody doesn't need it at the same time. And there's a lot of individualization that has to happen because, guess what? We're not all exactly the same. And I think what estrogen is safer for women as they age is another conversation that, that's what I spent 4 years of additional training to figure out. And there aren't that many of us. So I feel like that message isn't out there either.
So I think many of the answers today would be hormone replacement therapy, hormone replacement therapy, hormone replacement therapy. So at some point, we'll talk about the safety of that. Kelly, we know that women's health is understudied. We know that women's health related to women of color is even further understudied. With menopause, we know that African American women may experience menopause for longer periods of time, have more severe symptoms, but then they're also more likely to be disregarded in their exams. They may not be treated appropriately in their exams. Can you speak more to how health equity plays an impact on health in general and how we could create change?
Sure. So I am for a little bit of understanding on where I am in my ovary health journey. I'm 48 years old. I had a hysterectomy. I had my tubes tied in my late 30s and had to beg to have that done. I had 3 children. There was no way I was done at one. I was done before one, but I had 3, and I'm thankful that they're healthy, and so I was done. So I was able to fight to get my tubes tied, but I want to put a pin in that. And then at 42, I had a hysterectomy, a partial hysterectomy. So I have my ovaries, but I don't have my uterus. I was one of those young ladies who went through puberty, and my period was 3 days long. I had 1 day of spotting, 1 day of bleeding, 1 day of spotting, and I was good. I didn't know, y'all. I'm sorry. I was one of those. I am sorry, girl. What you mean you can't go to? We got to go out. I can't move. I can't. I had no understanding of what was happening to my friends. Then something happened, and I'm in the gynecologist talking to my OBGYN, and I'm like, I'm going to eat these MF's faces. You got to figure out what's happening to me right now. I'm bleeding. There's huge clots. I don't understand. It's taking all day. We can do this. We can do this. I don't want, take the whole thing. I went from, and I'm a cool, calm, and collected person. If you know me, But those couple of years between when my body changed and I started developing tumors in my uterus, I laugh now, but I really could not figure out how to not jump on somebody and literally eat their face. I'm not using those words. That is how I felt. Like I just wanted to. And I'm thankful I had my children early, so they were older and out of the house. It worked out because the kids would have been in danger. And so I was able to have the hysterectomy. But I also know that medicine has taught us that Black women are more likely to have their tubes tied and are more likely to have hysterectomy. So my fight wasn't really that much of a fight because that's really what they recommend you do anyways for Black women. And so a part of the health equity lens and why it's important to understand that, yes, we're generally talking about women's health, but especially Black women, because there's also a difference between how Black women are treated and how other women of color are treated. And it is okay to say that. It is okay to have that conversation. It is also okay to talk about the fact that we're talking about women, people who were born with the uterus or genetically were born and assigned the gender of woman. Whether or not that is what's happening in their lives today, right? It is okay to say we are talking about that group of people. That in and of itself is intentionality. That is understanding, and that is intentionality and understanding, and is in and of itself inclusive. We would be doing a disservice to people by pretending we're having a conversation we're not. So we are having a conversation primarily about all women, specifically Black women, and so this information is useful to everyone. That's my. When we look at the social determinants of health, so all the things that play into our health, where we live, what the physical building that we live in is like, our education level, our employment status, our accessibility to healthcare, our insurance types. Not just if we have employment, but do we have good employment? Do we have good employment that also has time off so that you can get to the doctor to be able to get the test because they're not open after 4:30? And you still have to pick up your kids or take care of your parents because we're in that space of taking care of all the people and our siblings. If you're one of those people that you're taking care of the siblings, if you're not one of those people and you have a sibling that is doing that for you, please give them a call and say thank you. And so we're in this place of all of the pieces kind of circulating and happening all at once. And with all of those things, I can tell you based upon the data, I am not a scientist. But based upon the data of the scientists, Kelly Marie Wofford, who grew up on Hughes down the street, who has a master's degree, half a PhD, started having her children at 17, has 3 children who are adults and healthy, who is still working, is generally able-bodied. Black Kelly will live 8 to 10 years less than white Kelly. That is equalized for education. That is equalized for money. That it's equalized for all of the things. So there are things outside of my desire to be healthy that keeps me in a space of not quite meeting that mark. Those systems, again, not being able to get to the doctor's office, people hang up on you because you ask too many questions. The doctor doesn't really have time because that's how the system is built. There literally is not enough time. If you're blessed to have a primary like mine, who is like, I don't care what they're gonna do. Everybody does not have that. You know what I mean? Like, right? She had to get to that point where she was safe in her career to say, I don't care what they're gonna do. I'm gonna see my patients. So I am blessed in that way. I should not have to give up 8 to 10 years of my life because the system does what the system does. And so that is one of the reasons why we're here today, because a part is advocacy, but a part is also knowledge. The part is being able to help us figure out, how do we say the things? How do we teach our daughters so that they can do better? How do we teach our moms so that they can do better? How do we teach our sisters so that they can do better? It is to whom much is given, much is required. And I know that I have been given a lot because I am Kelly Marie Wofford, who grew up on Hughes, who has 2 degrees, almost a PhD, that has 3 healthy children, that has a great job at the government, that pays me really good money to say really tough things, that gives me fabulous days off and vacation and all, right? Like, that is a blessing. And because of that blessing, I believe I'm required to be here. I'm required to be wherever you see me be. And so we have to be able to have those conversations with folks that look like us, that don't look like us. And what does that mean? Because what part of look are we talking about? Are we talking about complexion? Are we talking about language? Are we talking about demographics? Like, what growing up on Hughes is not the same as growing up on dope. What exactly are we talking about? And so we have to say what the words mean in order to understand what we're actually saying. Did I answer your question, Dr. Sosa? I'm sorry.
Thank you, Kelly. This is correct. Any questions from the audience?
I had I had a male surgeon specialist, and I'm thankful for a couple of reasons. I really needed to have some peace. I conceived all of my children on birth control. I don't follow directions well. I don't think it was the birth control's fault, right? Like, you can say that for one, but not all 3. And so I know me, right? I live with mental health conditions, and in order for me to show up, there's certain things that have to be off my plate. Remembering to take a pill at a certain time every day to make sure that you are able to take care of yourself and whoever comes out of you that was too much for me physically, emotionally, and mentally. And I had 3 healthy children. He said to me, well, what does your husband think? I don't care who y'all friends? Like, what do it matter? And so some women will be like, oh, I need to talk to my husband. Do he want his face ate? Right? So it's like some of it is advocacy, but the system is set up to not listen to us. It's also set up to not listen to Black women. Black women were used, their bodies were used without anesthesia to perform surgeries, to understand how we can birth children into the world. Our bodies were used for that. And that's not really taught It's taught in some spaces in medicine, but not really across the board. UB has been doing a fantastic job at changing the curriculum to be able to make sure that they're raising physicians to be able to understand and have these conversations. So a part of that is that the system doesn't teach doctors that I am valuable, that my body matters as a Black body. The system also does not teach that women are valuable as female bodies. And so you have two check marks. I live with mental health conditions, so they certainly don't have no care or concern for people living in that space. That's another check mark. And so that's a piece of it. One of the other questions he asked me was, well, what happens if something happens to your children? That ain't none of your business. I said, this is what I want. And so this is what I need you to give me. This particular doctor later went to jail for some medical stuff related to how he was treating patients. And so I'm here by the grace of God, right? Because I was one of his patients. And so I don't know that my medical relationship with him was ethical. I don't know either way, but I'm thankful because I was able to get my tubes tied and then went to a practice that was a little more legit and was able to see me through some other spaces and places. So it's that being seen piece. And most of us in here, there's only one person identifiably that I can see that in that particular situation, talking about a woman's health would be heard more seriously than the woman experiencing that. And that is our AV gentleman in the back, right? Like, so why are we asking him how my body should be regulated? Because you see the look on Jamil's face? Exactly. He's like, what? I'm here to... So why is his voice more important than mine when I'm talking about my body? So those are some of the reasons as a non-medical professional to be able to, kind of shed some light on why that happens.
Thanks, Kelly. One of the questions from the audience I'll direct to Dr. Singh. Does brain fog, well, I think there are multiple parts. So do brain fog, anxiety, and depression have anything to do with menopause? That's part one. And then does hormone replacement therapy help with that?
Well, I'm a psychiatrist, so I have to tell a story. So I'm going to start from the beginning. But I think it's important for women to recognize that hormonal shifts at every point in life will lead to mental health symptoms. So for men, their risk for all psychiatric illnesses increase as they get into puberty, they have hormonal changes. But for women, this happens multiple times during their lifespan. So our risk for all psychiatric illnesses are higher when we have puberty. It's significantly higher when women are pregnant and are breastfeeding. And then it's also higher when we are approaching menopause. So, like Dr. Berga said in the beginning, it's the fluctuation in hormones. That's the problem. It's not that the estrogen is falling or yes, some part of it is that we are losing the hormones, but the period that comes before the menopause where our hormones, I use the word turbulence, there is so much turbulence there, and that's what is causing, all these symptoms in perimenopause. And women who go through this period for a longer period of time will be at a higher risk as compared to women who go through this period for a shorter period of time. And we still don't know why some women will spend more time in this period and some women will spend less time. Some women will have more intense symptoms and some women will have less intense symptoms. So, we recognize symptoms like brain fog more than other symptoms that we are suffering from because it affects our ability to be productive in the community. Like we are not able to multitask. We are not able to perform as well because we have brain fog. And, it's such a vague term. that it's important for all of us to recognize that my brain fog looks different than your brain fog or somebody else's brain fog. So when you are at your doctor's place, it's important to tell them what is exactly happening. Is it that you're forgetting names? Are you forgetting the burner on? Like what extent of symptoms you're experiencing, and that will determine what kind of help you will need. Because if you have a lot of intense symptoms, you want to make sure you're not missing anything else medical going on. But yes, brain fog it happens. It is true. For some, and also women you will notice that there will be periods where you will have more of those symptoms when your hormones are very fluctuating a lot. And then there will be periods where you won't have that symptoms, and that confuses us. Is it in my head? Is it really happening? Was it happening, or did I feel that was happening? But yes, these symptoms happen. They fluctuate a lot. And the other part was, well,
anxiety
hormonal
and depression during menopause.
Yes. So like I said, with hormonal changes, our risk for all psychiatric illnesses, including anxiety, depression, goes up during puberty, during pregnancy, breastfeeding, and then during, perimenopause and menopause. And we are talking about menopause here, but truly speaking, the risk for depression, anxiety, and other psychiatric illnesses comes down a little bit. It's the period, that's the perimenopause, before women achieve menopause. That's the time where it's significantly, significantly higher. So women who are not in this period, where they're having their periods regularly, the risk for depression, anxiety is about 30%. For women who are in perimenopause, the risk ranges anything from about 50 to 70%. So most women will have some amount of mood symptoms during this period.
And from your expertise, because you treat anxiety, depression as a psychiatrist, and so you have your SSRIs, your SNRIs, which are just the groupings of the medication we use to treat anxiety and depression. How do you help differentiate whether a patient needs those medications versus hormone replacement therapy to help their symptoms?
So something that has helped me over the years is asking my patients what are the one or two symptoms that if I can help with, would help you the most. So what is the most distressing symptom? And that's what helps determine treatment. So, depression, anxiety for me looks different than depression, anxiety for somebody else. It's never the same. I hear a new story about same diagnosis every day. So, for some people, it could be trouble with sleep. It could be that I'm having a lot of hot flashes. It is that I feel sad or I feel anxious. So the modality of treatment will depend on what symptom is most distressing. Depression doesn't look different. It feels the same. It's the same sadness, not wanting to do things, not feeling motivated. It feels the same like any other time of your life. But if depression is the most prominent symptom or anxiety is the most prominent symptom, then the treatment would be an antidepressant, an SSRI or an SNRI. And if you have tried a medication in the past that has worked really well for you, then that would be the first medication to be tried again. If your symptom is hot flashes, then there is a different medicine that should be treated. If your main symptom is sleep, then that should be the target of treatment. If your symptoms are you are sad, but you also have a lot of perimenopausal symptoms, like you have lots of joint pain, you have reduced interest in sex or intimacy, you have urinary problems, you're having a lot of hot flashes, if you're having a lot of cognitive symptoms. So if your symptomatology is more about physical symptoms, then maybe hormone replacement therapy is the first line of treatment that you need.
Do you ever see patients on both?
Yes. So, for example, if a patient came to me and their prominent symptom was depression, so I would start with an antidepressant. And my hope would be that as the depression settles down, other symptoms will settle down too. Sleep will get better. There is lots of evidence that using an antidepressant like an SSRI or SNRI can help with hot flashes too. So my hope is that, once the mood gets better, sleep gets better, other cognitive symptoms of depression, anxiety causes a lot of cognitive symptoms. So the cognitive symptoms will get better.
What do you mean by cognitive symptoms?
Oh, sorry. So cognitive symptoms would be forgetfulness. You're talking to somebody and in the middle of the sentence you forget, what was I talking about? Or, you're rushing to get to your room upstairs, and when you're in the room, you're like, I have no clue why I'm here. Right? Forgetting names. So you've known this person forever, and then you see them at your grocery store and you're like, I know you really well, but I can't remember your name, and feeling, awkward in that situation. So those would be the symptoms of, brain fog or cognitive symptoms. So, if this patient, so we start, I started the patient on an antidepressant, and my hope is that their mood will get better. And as their mood gets better, other symptoms get better. But the mood gets better, but other symptoms don't get better. This patient is still having a lot of hot flashes. They have a lot of urinary symptoms. So they're needing to go to the bathroom very frequently or have a lot of urgency. Their sexual desire is still low. They're having a lot of hot flashes. So yes, the mood got better, but the other physical symptoms did not get better. And then this patient would be a good candidate to do both hormone replacement therapy as well as an antidepressant.
Thank you. I appreciate that. We have several questions coming down the pike. One of these is from a patient who's in her 30s, Dr. Berga. What can she do to prepare? Should I be getting my hormones checked?
Is it on? Yeah. You don't have to really, it's not easy to check the hormones. That's because every cycle is different. So you could test in one cycle and you could be ovulating and it could be perfect. And the next cycle you could have low estradiol levels followed by very high very high. So start low and then go high and fall again. And so at any given moment, the estradiol level could be high or low, and it wouldn't tell you much about what's coming around the corner or what went right before. So we do have a test, and people are ambivalent about using it for this, but it's been shown to predict menopause, and it's called AMH. And it does actually tell you when you're close. It doesn't tell you the day, but it ballparks it. And we use it for fertility, for telling patients who are thinking about fertility where they are in their ovarian life cycle. And there are lots of controversies around this hormone, but it was an NIH product that took years to develop. It's a tricky hormone to measure, but you can. And we're still trying to figure out where it belongs in our understanding. But if you've been through menopause, it's useless. Everybody is low. So then you don't really need to know where you are, because you're low. So it's that water before the falls. And then once you're in the smooth part of the river, you're in low. But then there are the later consequences of low hormones. So I always like to start with a trick question. Who has higher estradiol levels at age 30, men or women? That's Kelly. You got the drift. It's even worse. It's even trickier. They have the same. And so what differs is that men have more testosterone. That testosterone gets turned into estradiol. We have a little testosterone, but most of our estradiol is coming from our ovaries. So when the ovaries start to sputter, then we have fluctuating estradiol levels, which cause lots of symptoms in lots of tissues. And if you have new onset symptoms associated with new onset menstrual irregularity, we tend to think that's probably perimenopause, and you don't really need your estradiol level measured. You need it stabilized.
Thank you. How do you know when you have finished menopause, and what does that look like?
Well, I'm going to make a commercial. Why are you waiting to find out when you're in menopause? Most people don't want to wait that long, right? Some people do because they get dismissed, and there's a lot of hysteria around this whole thing. And there's a lot of, I would say, among OBGYNs, there's a lot of controversy, and not everyone feels comfortable with the topic. So you could get actually a cold shoulder anywhere along the way and not get the help you need before you go through menopause. But a lot of people get scared, and there's been fear for years. And we've been working on combating that by helping people understand. But I would say that it has been a very hard journey. So I've been doing this for 40 plus years. My own daughter is going through perimenopause right now. It's painful for me to watch that this goes unaddressed all these generations. That's actually my main message, and why I am still practicing after all these years, because I want us to understand that our hormone, estradiol, is not a carcinogen. And that sounds very misogynistic to me to call it that.
What's a carcinogen?
So a carcinogen is something that causes cancer. And estradiol and all the relatives, which are called the estrogen family, have been labeled as cancer causing, but none of the male hormones. And I am always agitated by this concept that our hormone is bad for us, their hormone is not. And I think that is a really big societal issue that we have not addressed. And I actually wanted to go work for the FDA, but then you have to swear allegiance to certain people. I couldn't. It's true. I was like, oh no, I don't know if I could make it. I'm not that good at hiding my feelings. And I don't know if I want to. But the FDA they have a little branch, and I was interviewing there, and I thought, oh my God, this isn't the oasis of enlightenment that I would like it to be. And I don't want to necessarily give up what I have now as a career to go there, but I really do want it changed. And I'm tired of the stigma that causes when you have your conversations with other doctors. When I have conversations with other doctors and they look at me like they don't understand it, because they've already been tainted by this notion that our hormone is bad for us. And I've been working on this forever, and I still feel like I'm not getting where I want to go. But I have hope, because I was the next generation. There's a person sitting in the audience who's going to be a doctor soon. She's a medical student now, and I think I'm in the job that I am now to influence the next generation. We have one of our residents here who is actually working on health disparities and infertility. I'm so proud of her. So I feel like we just have to keep banding together. And I want to share some good news. The state of Rhode Island passed a law in July saying that there has to be time off from work for menopause care. I think either you or you mentioned that, yeah. And my daughter said, we need to
have a talk with Kathy Hochul.
It says that Rhode Island is the first state to enact workforce protections for women experiencing menopause. And I thought, oh, that's so good. Yeah. So that's hope too.
Dr. Berga, we're going to keep you talking because we've had some questions regarding cancer. You mentioned the fact that our hormones are treated like carcinogens, that estrogen causes breast cancer, causes all these other issues. And we often get questions about whether hormone replacement therapy is safe. So can you tell us more about the benefits of hormone replacement therapy as it relates to the symptoms of menopause versus the risks of cancer if you were to take it?
Okay. I like to distill it so you can remember it. So not all estrogens are the same. I said that already once and I'm saying it again. It matters that there's a lot of detail there, and I did a 4-year fellowship in this topic, so I'm not going to bore you with it, but they're not all the same. And so not everyone's risk for cancer is the same. So you need to have a good family history. You need to have a risk assessment. You need to be up to date on your screening. And it is a conversation, and then you have to individualize the intervention. So everybody doesn't get the same thing, and everybody doesn't have the same risk. But when we look at it from a longitudinal risk benefit ratio, there are risks in the short term, and then there are the longer term risk. I see a lot of women who are in their 70s, and they're struggling with things like joint pain. It's not mental, disability in their minds anymore. They're not having hot flashes. They're not having night sweats all the time. But they are having what they would say are hair loss, vaginal dryness, not feeling energetic. And it's different set of complaints than you see in the perimenopause. And they've been told all these years that none of that's related to hormones. But a tiny amount of estradiol in a 70-year-old often relieves their joint pain, gets them moving, helps them with hair loss, helps with teeth and gums, things that you start to worry about. So it's more subtle as you get older to attribute this to estradiol, and it's more subtle how you treat it. So again, this conversation often gets distilled into too simple of a soundbite because there's a lot of complexity that we have to grapple with. And as a physician, my commitment is to not treat everyone the same, but to try to risk individualize and to help people understand what the risk benefits might be for them, and to help them, as Dr. Singh said, I ask what are your top complaints, but also to point out that some of the things that you think aren't related to hormones might well be, and that we want to keep you healthier for longer. So I was just last week with my 96-year-old mother, who I did keep on hormones for as long as I could, till the doctor just absolutely refused to help anymore. But I think she's 96 and walking and thinking and knows her great-grandchildren if they're sitting in front of her. But I mean, you want to have your older generation with you as you age. And they say there's nothing, I know I have this, I have a commercial, but I have spent my life thinking about saving grandmother's brain. That's like a core value for me in my office, because I think children do better who have grandparents. We don't have to talk about that here today, but I think I want everyone to have that option if that's what they want in their lives, every child to have a grandparent that cares about them. I just think it's a societal attribute that we want to foster.
Thank you. So what I was hearing too is that we might be surprised at how much safer menopause hormone therapy, or HRT, is versus what you may hear in the media, what you may have heard from other family members, right? That the benefits far outweigh the risks, and it's really important to have that conversation with your physician for that individualized care where we assess your risks to see whether it's a good option for you. And the other thing I heard is that menopause hormone therapy could help many things outside of just hot flashes. And so it's important that we, again, have those conversations and go to your physician who can assist you in that process.
Hi, my name is Dr. My name is Dr. Bernard Joseph. I am an OBGYN resident. I work with Dr. Berga and Dr. Sosa in Collider facilities. We have been saying hormone replacement therapy. Well, what does that look like? Is it a pill? Is it a gum? Is it a patch?
I feel like now I should make you answer it, resident. Go ahead.
This is not a test.
We have an empty chair if you want to join us at the.
I feel like I got myself in trouble, but can I decline?
Yeah, so hormone replacement therapy, and I invite, we have other OBGYNs in here, Dr. Rush, Dr. Nylander, they're here too. Feel free to jump in. Hormone replacement therapy could take several versions. There are pill versions, and so I guess we should start from the fact that most times the replacement is for the estrogen, the estradiol, and we give medication for that purpose. However, estradiol alone should not go unopposed if you have a uterus because it can cause uterine cancer. So we give progestin, so a progesterone type containing medication to help protect the uterus. So if you have a uterus and you have to take hormone replacement therapy, you need to have both estrogen and progesterone. If you'd had a hysterectomy, you don't have a uterus anymore, you could just do an estradiol, estrogen form of hormone replacement therapy. So they could be a pill, they could be a patch, it could be a gel that you rub into your skin every day. Am I forgetting a version? The rings, the fem ring and S ring. There's one that you could have in place for 3 months, a ring that you place vaginally for 3 months at a time. So those are the options. There are ones that are combo that would have the estrogen and progesterone. We often, what limits us is what your insurance may cover. So though a certain option may be ideal for you, some insurances don't cover. So then we have to try something different, a different combo. So you may need to take a patch and a progesterone pill to protect your uterus versus the combi patch that has both estrogen and progesterone in it. But if your insurance doesn't cover, then you have to break it up so that they'll cover that. Any suggestion, any other things I left out, other OBGYNs?
It may or may not help with the vaginal part of that. So I sometimes will use a combination of both, especially if you have vaginal dryness, because the oral or even I like to use parental on the skin. You have a little less chance or risk of having a clot, a pulmonary embolism or blood clot in the leg, using it on your skin with a patch or with the cream sprays, etc. I kind of find that the sprays and the creams aren't sometimes covered by insurance, which is really annoying. However, the patches work very well, and you can go up and down in the ranges of how much you're going to be taking. My question, and sometimes I do actually use testosterone with that also, and it's compounded. Another annoying part about that is some insurances cover it and some of them do not, and some of them can be very expensive. Just like your SLGs. If you go through the insurance companies, they're charging you so much money, and then you can go through a compounding pharmacy and they charge you like $35. And I'm like, how do you get from $35 to something that's $150 or even $500? That's ridiculous to me. I think if we're going to be fighting about things and advocating, number one, advocate that this stuff should be covered because it's a health risk. Number two, why are women in Medicare, Medicare having to go are you okay? Having to only come twice every other year if you're not quote unquote high risk. I get so many women who fall through the cracks with their symptoms because they really can't afford to come in and pay out of pocket. And then I guess lastly, yes, why are we having to pay so much money when can you remember what was that medication that came out for the guys? Thank you.
Give it away for free.
I think, yeah, I jokingly said when that came out, if they give this to these guys for a less amount, I will lose it. And I lost it. So to answer the question, there's many ways of giving hormonal replacement therapy. It really does depend on what your symptoms are at the time and what your risks are and what you feel comfortable with. And that's when you sit down and talk to your physician about it. Oh, I know what I wanted to say. Telehealth. Because everyone can't take off of work to come in. So I kind of find it very easy. My last patient was sitting in the closet at work
Trying to talk
going through hormonal replacement. It was wonderful. It was a 15-minute conversation, but that's coming off the board. They don't want to cover for that too. So if we're going to advocate for anything, pay for the visits, pay for telehealth, and pay for the medication.
Thank you, Dr. Rush. Kelly, any comments there?
Just I had a thought when you mentioned the closet, and perhaps there's a way to make a recommendation. I'm first drafting this, and I know this is just a suggestion for the camera, to take or combine lactation rooms in workplaces and combine them with we recommend that you have a sign up sheet on your lactation breastfeeding chest feeding and lactation friendly workplace designation includes a sign up for time, but perhaps employers to really begin to change that equity piece is that can also become a place for telehealth appointments. So just a thought, because I'll forget. So just
It's recorded.
as a thought to consider. Yeah.
Very nice. I'm going to ask Dr. Wendy to comment about this, if you're aware. So Dr. Wendy is the dean of the School of Public Health and does quite a bit of research. Can you speak more about the landscape of federal funding in women's health? You're like, where do I start?
Wow. So
what percentage of federal money is geared towards women's health?
So back in the late 1980s, there was a commission to look at the issue of women's health, and what was found was pretty substantial. Virtually both NIH funding and funding from pharmaceutical companies was very low in women's health. About 70 to 80% of all research was done in men, and often those findings were applied to women without studies. And at that point, the NIH made a commitment to fund more women in science, because if women were trained, they might want to do more about it. They set up an office on research in women's health, that the focus was to start studies, Women's Health Initiative, which Sarah and I both, Dr. Berga and I were both part of, continue to be part of. They also recognized that it wasn't just women's health, but if you looked at minorities' women's health, there was virtually nothing being done. So it started a change where all grants had to include women and had to include minority women. And we have made some progress. We're still not there. Just a few years ago, they finally said you had to do research in animals on women, female animals, because often it's done in males and it doesn't interpret correctly. So we have been making progress. There have been more studies funded, more focus on that. until recently. And you may have heard the 200 or so words that you can't or are not compatible with the current administration's focus. And that includes equity, diversity, inclusion, women. Women. And I had a personal experience. A study that I've been doing for 32 years was canceled. We got notified by the New York Times. That's how the investigators found out this was happening. It only lasted 3 days because there was so much outrage from women that came and said, "Are you kidding me?" But the priority was not for women. So I think this fight is starting all over again. And, not just women's health, but minority health, studies on equity, diversity. I have a young faculty in my school who was doing research in Ghana on Black men and women who were HIV positive. She had her study pulled because of legal reasons. It came back. We had at the university a P50 that was about minority health that was pulled and now is back again. But this is an administration right now that is calling for a 40% cut at NIH. Dr. Burstein, who worked at CDC, the Centers for Disease Control, have been decimated. NIOSH, another form of the CDC, is essentially non-existent anymore. And it is a very scary time for research, but know that women, minority health are two of the areas that are really being pushed back by this administration. So we're hopeful that this won't happen, but right now, depending on that big, beautiful bill, they could be cutting NIH budget by 40%. And then the other piece that I'll let you speak to is the potential cuts in Medicaid that are going to be devastating for people's health, but especially women's health. So,
thank you, Dr. Wendy. We have a question for Dr. Singh. When we spoke about the hormonal turbulence that affects mood, how then can we trust our own thoughts and emotions if we know this is all secondary to hormones? And how do we talk to family members and partners about what is happening to us?
I think the most important part to focus on is your quality of life. If you're suffering, then you should get treatment. I feel like I hear this more and more that, okay, this is temporary, this is hormonal, I'm unwell right now, but I will get well. And, the worry about risk from medications, is it really worth exposing myself to medications? And, people will make choices based on what their social support looks like, what their financial support looks like. If they are the only earning member in the house and not well, they are more likely to get help. So, I think the most important part is if you feel you're unwell and you're not able, and all these symptoms are holding you back, then it's important for you to seek treatment.
Thank you. And I want to add that those small, not necessarily small, don't necessarily think that it just affects one aspect of your life, right? So you may have turbulent emotions, you may be depressed, you may have difficulty sleeping. If you're not sleeping, then what do you do when you wake up the next day? You chug a bunch of caffeine, you might eat more, you don't have the energy to exercise. So then now your heart health is affected. So see how one thing just sort of connects to the other. So when you are in distress, and again, you may be fearful of medication, or you're fearful of even just letting others know that this is how you feel, understand inaction is not just inaction. Inaction has its own corollaries, that sort of a domino effect that could affect other systems in your life. So fixing that one thing, working on fixing that one thing, could actually benefit you in several other ways. Question?
Little concern on, I have leakage for urinary, but then I also have the menopause issues with estrogen level issues where I'm not, I have dryness and intimacy issues. So when I talk to my GYN, then they want to send me to psychiatrists, and then it seems like they're not helping me enough. I didn't just want to talk about that, and then they never wanted to prescribe pills for me to help me with my estrogen levels. So thank God my husband still, deals with the process, but it's still no help for me. So what can I ask for with my GYN?
That's a tough one. I have to make the disclaimer that I am not your personal doctor, and I cannot give you direct medical care in this scenario. However, this is for educational purposes. One, I guess, if you don't feel like your doctor is listening to you, you could find another doctor. That's step one. Really. And I know it's not easy necessarily to find another one, right? You got to think, who's in network? How do I actually know this person's good? Do I have to go see them a few times before I get a feel for who they are? But ask around, family members, folks, talk to people that see if they are happy with their GYN, and you may need to switch. Vaginal symptoms with menopause, and we talked about options for treating with hormone replacement therapy. Vaginal estrogen is an option that is probably one of the safest things to use, to do. Very low risk, easy to prescribe, oftentimes covered. I am quite surprised that that wasn't recommended, given the symptoms with intimacy and with vaginal dryness. That's straightforward. There are very few cases where we would not prescribe vaginal estrogen. Really, very few. Do you agree? Yeah.
But the other thing is, it's not psychiatric, this vaginal dryness. Just going to say that. Sorry, I just can't help it.
You are being gaslit.
This is not uncommon experience. I cannot tell you how often we get referrals in our office, in our psychiatry practice, where the female patient is calling saying, my doctor wants me to see you. And then we're like, why does your doctor want you to see us? And they're like, I have no clue. I was just told to call psychiatry. And one, not that that is right, but one of the bigger challenges here is that a lot of the symptoms that come during menopause can come from psychiatric disorders too. So problems with sleep, having poor energy, having difficulty focusing or concentrating, all these symptoms can also be symptoms of depression. And my hope is that as more awareness happens, that, physicians are able to recognize that they are not just symptoms of depression, anxiety. They can happen from perimenopausal symptoms as well.
It's always been difficult to share the brain because we know that it's a target organ for hormones, but it also has its own issues, right? So pre-existing conditions can be amplified by perimenopause. It's true. It's also true that people have new onset symptoms at the time of perimenopause. And for years, we have been sort of encouraging the concept that if your symptoms began at the time of hormonal changes, then try some hormonal therapies first. And then if that doesn't get you where you need to go, seek additional care. Because it is upsetting to think, and the studies show that there are new onset symptoms that are really probably related to hormone changes, and those don't necessarily need the kind of psychiatric care that if you had a pre-existing condition that amplified. And the other thing I think that people sometimes forget is that when you have urinary symptoms, there's a specialty called urogynecology, and there are several good urogynecologies in Buffalo that really provide excellent care. So you can be evaluated, because we don't know if you have a hormonal issue with your incontinence, or if you have a anatomic issue, or if you have both. Well, it became a subspecialty, and in some ways it makes it a little harder because all of us used to do a little, but their subspecialists actually have new techniques for urogynecology, and they do a better evaluation than we used to do, I think, in the past. So it became a subspecialty because it grew up and there was more to do. But there are very good ones here in Buffalo. You really just need to plug in the word urogynecology.
Mm-hmm.
Oh, I'm sorry. I thought it was loud enough. Sorry. Okay, so for community members or women that have not yet made that appointment, because sometimes, appointments can be a little, you're not going to get an appointment tomorrow, or they're, still struggling with, any kind of access or equity, or maybe they don't have insurance or whatever the case may be, to get to see a provider. What are some things that they can do to mitigate the symptoms that they're experiencing now? You mentioned sleep, but are there some things that, and some women may not think about medicine, in terms of alleviating their symptoms. Are there some things that they can do? And I'm a psychiatry too, so I'm like, but from just from a non-medicinal, until I get to see you all, are there some things that they can do to alleviate their symptoms right now?
Yeah. Baseline, I think we talk about it in healthcare a lot. Healthy eating, exercise, prioritize sleep. Now, is that easy to do? No, but that's what we recommend. There have been those of you who took the menopause brain book. She talks about, Dr. Mosconi talks about that often, how the Mediterranean diet, which involves lean proteins, healthy fats and oils, non-processed, non-sugary foods, whole grain carbs, having a diet with a lot of those included in your diet helps to optimize brain health, reducing your risk of dementia, Alzheimer's, which women, 2/3 of Alzheimer's patients are women. And we believe that some of that is related to how the lack of estrogen affects the brain. So eating healthily would help mitigate that, especially healthy seafood. So salmon, tuna, sardines, my favorite fish. Those are really good for brain health. But also you can't say, oh, I eat salmon 3 days a week, therefore I will never have dementia. It's really about making this a lifestyle thing, right? That you're going to do this every day, most days. I talk about having a colorful plate. So lots of greens, orange, red, yellows on your plate. That is not from dyes and whatnot, but really just from your vegetables and fruit. Doing those things. Exercise regularly. We know cardio, 150 minutes per week of moderate exercise is what's recommended for good health. If you divvy that up, it would be about 30 minutes, 5 days a week of exercise. Walking, just that is way better than anything else. So you don't have to have a gym membership. You could just take a 30-minute walk, take it during your lunchtime, take it after work. Strength exercises, so the ones where you have to use your body weight or a little bit of a dumbbell can help. So planks, burpees, squats, lunges, then those dumbbells where you do arm exercises, those help us particularly because the estrogen decline can affect muscle mass. We have less muscle mass, which means we burn less fat, which would explain why many of us come in saying, Why am I gaining weight in perimenopause and menopause when I didn't change anything else? It's because our muscle mass is decreasing and we cannot burn fat as well as we did before. So we hold on to a little bit more of that. So exercise and strength training in particular, not just the walking, but the strength training helps you build muscle, which therefore helps you burn the fat. You build muscle, you have stronger muscles, stronger bones, you may have less joint pain. You may have increased mobility. So again, seeing how those changes could affect multiple organ systems and affect your overall health. Dr. Reed.
Right? So it's more important that you do the exercise. If it's 5 minutes in the morning, 15 minutes at lunch, 15 minutes later on, that 30 minutes of activity per day, right?
You could dance. You could.
And then the other, dance, absolutely.
Apparently people who dance are happier than everybody else.
And the other thing that I wanted to say in terms of you're trying to think of natural treatments for some of these symptoms is also to avoid things that make things worse, right? So avoid caffeine, which we know makes hot flashes worse. Wine, alcohol, worse. So things like that as well. I'm not giving up my wine, but
No, actually, red wines make you hot.
Red wines more so, yeah.
I don't like either, but white wines make you hot flash less. Something as simple as some magnesium, and there are, I think, 4 or 5 different types of magnesium. So please don't go out and get citrate or oxide. You're going to be in the bathroom. So you might want to try some magnesium glycinate. I think it's about 200 or 2 to 400 just in the evening. That might make you relax enough to go to sleep.
Vitamin D.
Yes. Vitamin D, 1,000 to 2,000. And if you take it, try to get the form that has the K2 with it. And lastly, something as simple as, I say, go to Dick's, go to the men's section where they have the running outfits and with wicking. For those of us, yes, who woke up and you were hot as whatever and you were sweating, that at least will draw a little bit of that wetness away from your skin so that hopefully you're not waking up and you're just freezing now because you're soaking. I used to keep a little fan. I am somewhat past it, although I still get my little heating moments. But I would take a little portable fan and I had it clicked to the top part of the bed away from my face, but enough that it gave me a little nice breeze. So that, number one, your husband isn't complaining that you got the house freezing, but enough to just make me a little bit more relaxed. So those are some simple things that you can try thinking about doing that I kind of talk to my patients about. I am not giving up caffeine. Sorry, not happening. But I have a little Keurig cup that's 10 ounces, and I only do 8 ounce, and that's it.
Can I add some to just from a non-medical personal journey place? From a health and wellness perspective, I would always talk to your doctor. But developing a sleep routine, right? The body and brain loves a routine. And so go to sleep at the same time every night, wake up at the same time every morning, regardless of what you got going on. I like to sleep in late on Saturdays, but I know for me, I need that routine. But also a daily routine. And so if you have the kind of life that is just all over the place, you're doing all of the things, you can still begin to put your life in a routine. So I'm not telling you to drop everything and don't do nothing for nobody else. I did that, but that's not what drinking water, to keep the body hydrated, changing your healthy eating habits. And so some of us, we are at different places in life and buy groceries and can afford groceries in different ways. So if you just take a step towards healthier, if you're buying, canned goods, take a step towards frozen. If you're buying frozen, take a step towards fresh. If you're buying fresh, I have issues with organic. Organic does not mean healthier. It just means it works, right? So that wash your vegetables better. Something like you know what I mean. So I'm not saying once you're in that, if you are in the healthier, like the healthiest of the foods, then using olive oil instead of cooking oil. Those types of things. Cut back on the amount of salt you use. Switch from fried to baked. Not all like if you need something fried, like then go ahead and get that, right? Because you need that, and you're gonna end up eating more food because you didn't do that one small thing. But if you're eating fried food every day, like make a change to preparing food healthier. Mental health routine. Because it may take forever to see one of these experts, begin tracking your symptoms. What is it all Mondays? Is it the weekends? Like what does stress look like? You don't have to have a fancy app. You can use a notebook. You can use your phone. It doesn't have to be a fancy phone. All of the phones, if you ASK, Siri or Google, they will take the note for you. But don't say ASK until you're cancel, delete. You have to be ready for it. But you don't have to have all the information up here. Use the tools that are around you to be able to make some of those changes. The walking part, if you take the bus, because, mobility, as far as having a car is an issue, walk to the next bus stop, right? You can park further away from the door. There are ways we can begin to make healthier changes that are not overwhelming and daunting. You're just tweaking what you do a little bit, and those are more likely to stick.
Thank you, Kelly.
I just want to say, don't buy expensive vitamin pills. They sell these designer vitamin pills, and it's really totally not necessary. They're not any better. Sometimes they may even be worse. And they're mega vitamin story. People are selling things for menopause that really might actually be harmful because the doses are so high. And I see lots of people walk into my office on something they got at GNC, a mega dose of B vitamins, all this stuff. Honestly, when we've looked at it, it hasn't worked out. And in some cases, it's been harmful. So while you're waiting, don't go do something harmful. And don't buy, like I had a patient, $500 of vitamin pills a month. I mean, like that should just be $500 of better food, right? Than those vitamins. So we do think it is buffalo, and you don't get enough vitamin D in the winter because the sunlight is somewhat not good. And I used to say you could strap yourself on the roof of your house and not get enough vitamin D in buffalo, but you would die before you did that. But there are some vitamins that you need, and vitamin D is one of them. And if your skin is dark, you need probably to really pay attention to it. So those are little hints, but I think a lot of times people go out and buy all this stuff, and it's quasi-imaginary. There's all these herbal medicines really took a show in the 90s, and people tried them, and they were studied, actually, and they didn't help, and they cost a lot. And they're not always what the label says. So sometimes you're buying something harmful that's not even what the bottle says it's labeled as, because it's a relatively unregulated part of the universe. And I always say that is the thing that scares me the most, that someone goes out, they buy like a very expensive set of vitamins for their menopause, and they actually cause themselves some harm. So do buyer beware.
Thank you.
Oh, very expensive. Well, I haven't seen that one yet, but maybe I'm missing something. Yes, you will have very expensive, but not all of them pee out. Some of them are hepatotoxic. Yeah, honestly, this makes me nervous.
I think my question is sort of, sorry, do you want her to go first?
Hi. I would like to start off by saying I am not giving medical advice. If I need medical advice, that lady standing there is who I call. One of the things that I was blessed to have in my life, I'm actually 77 years old and beautiful, was an OBGYN, and she was actually from India, and she was Muslim. And when I started having problems with menopause and tumors and everything that could possibly go wrong inside the uterus, I called her, and at that time, She came to my house. Doctors don't do that anymore, okay? And she sat down and she explained to me the things that I needed to do in order to have longevity in my life. And if I did those things, she said, no guarantee, but I can tell you this much, it won't harm, it will help. And it did. I was to the point where every time my menstrual cycle started, I almost hemorrhaged to death. My hemoglobin dropped to 4, if that tells you anything, okay? And she told me, she said, you can wait to see if it's going to self-correct, which I tell you it's not, or you can do A, B, C, X, Y, Z. And I'm not saying what those things are because you seek your own doctor and let your own doctor tell you what those things are. And I did them. And I did not have to have a hysterectomy. When I turned 55, it ceased and desist. Okay? And they waited 1 year, and God has a sense of humor, and it came back. But it was because I had developed more, I guess you could, fibroids. It had grown extremely large. And she said, I'm going to give you some medication that should shrink them. And it did. And I never had to have a hysterectomy. I exercise every day. I eat well. I follow the Mediterranean diet. And I do get brain fog, as you see it taking place now. But the bottom line is I've lived long enough to see my grandbabies. And I've lived long enough to continue to do what I do today, and I'm able to teach young women. But one of the cards that I gave you, one of the things that she brought to my attention, she told me to stop perming my hair, stop using chemicals in my hair. She also told me to stop dyeing my hair. Go natural, lady. That's what she told me. I went natural, so I will share that with you. Okay, now this is natural, but I bought it. The other things that she shared with me all benefited helping my body and not increasing the problems that I was experiencing at that particular time and moment. Today, God bless her, she is retired, and I still on occasions get an opportunity to talk to her, and she was the one who brought to my attention about the bundles. I didn't even know what bundles were. They're braids that people braid into their hair. California has already outlawed some of those bundles that come in because they contain lead, which is a carcinogen, that basically has an input, and it's only for black hair the bundles are that's causing. This country just experiments. Everybody experiments on us. But the bottom line is that we need somewhere where somebody does the research that I'm not going to try to do, okay? And find out if all of that information is really true. Put a billboard up. How much does it cost? Tell me. I'll fundraise and put one up for you once you get the information and it's correct, okay? So the bottom line is that if we take care of us and we spread the information that is beneficial to all women, but especially women of color and African American women, then we're saving a life, saving babies, saving a country, saving a city, saving a nation, saving the world. And that's all I've got to say. Thank you.
I think some of my question had been answered, but I know we'd been talking about vitamins and minerals and maybe vitamin D being helpful and magnesium, but what about, I know I have a lot of friends who are taking supplements that are not typically vitamins or minerals. I'm hearing mushrooms and black cohosh and yams and all of these different things, and I'd be curious to see what you all are telling women who are coming in asking about these supplements.
I can answer the question about black cohosh and the soy supplements. So there was a period of time where there was a lot of this thing about black cohosh and soy containing products helping with perimenopausal and menopausal symptoms. But there have been 2 really large studies, both with black cohosh and with soy containing products, that have not shown any benefit. And like, Dr. Berga said, that, these over-the-counter medicines that you can just go to the pharmacy and pick up from the counter that you don't need a prescription for, they are not regulated. They come under food. So most of the time, we don't even know like the amount that is in there. There was a really large study around melatonin. So scientists picked up 30 samples of melatonin from across the country, and out of which 10 had no melatonin in it. So these were 3 milligram melatonin tablets. 10 had no melatonin in it. Some had 0.3 milligrams of melatonin, and some had 30 milligrams of melatonin. So we have to be really careful when we are buying things over the counter. And that, like, as of today, there are no natural supplements that have shown to be better or more effective than the medications prescribed for any mood symptoms, for perimenopausal symptoms.
Thank you, Dr. Singh. I think it's important to note what you're saying is a lot of these vitamins and minerals that are recommended we can get from food. So make food your first medicine too, okay? Yeah. And on the topic of longevity that Reverend Diane had mentioned, all these ways to prevent, these natural ways to intervene with your health, the studies show that the earlier you do this, the better. And so this is part of the reason why we're doing this. And we mentioned 35 onwards, when you take these actions, exercise, food, sleep hygiene, minimizing alcohol and caffeine when you can, the earlier you do that in your 30s and 40s, it helps you when you're 60, it helps you when you're 70, it helps you when you're 80. If you start when you're 60, yes, that's beneficial, but it's even more beneficial to start younger. So making this a lifestyle, making those little shifts towards whatever your goal is earlier on establishes the foundation for you to thrive at 77, for you to thrive at 90, for you to be the person that lives longer. And even if you don't live as long, to be alert, to have good memory, to be able to move around. Those things matter. Those are the things that we want as we get older. And so making those changes from today, no matter your age, will positively impact your future.
Can I just add, I read somebody's proverb, I don't know whose, but it made sense. The best time to plant a tree was 20 years ago. The second best time to plant a tree is today. So yesterday's gone. We could have, should have, would have, but to your point, today is the day.
I have an interesting question about chemotherapy's effect. If you have chemically induced menopause because you've been on chemotherapy, how do you know when you're naturally in perimenopause? How do you know if this is because of the chemotherapy or not?
You're looking at me. So there are different kinds of chemotherapy, and there are actually the Easter Bunny wasn't good to everyone. So the truth of it is, when it came to eggs, there's about 100-fold difference between people. So some people have a lot, and some people have little, and they go through menopause and perimenopause earlier than others. Some go through later. If you took chemotherapy for a childhood cancer, a lot of times it doesn't actually change your age of menopause because the clock readjusts, but it depends on what chemotherapies were given. I have a patient who's a childhood survivor from Roswell Park who has a higher egg count than 90% of the women I've ever met. And I think it had to do partly with the kind of chemo she got and partly the age at which she got it, which was before puberty. So there's a lot of, I started an onco-fertility program twice now. This is fertility preservation for people with cancer. And there's a lot that we are learning and a lot more to learn. But I actually think this is something that we need to focus more on, because we have learned that people who suffer cancer and who lose their fertility because they were young when this happened and no one talked to them about it really have regret and are anxious and upset that they were not attended to at the time of their trauma. Going forward, now that we have more to offer people, there's lots that we can do. But for people who went through it and had this, then it comes down to what kind of chemo you got and what kind of cancer you had. And then there's a discussion, because I used to say, if you wouldn't take the ovaries out for this condition, there's often no reason to deny what I call Mother Nature HRT. This is something that's just like your ovary. And because of the fertility industry, we learned how to mimic exactly what the ovary does. And we no longer have to have things that are strangers to us in our bodies. So there's been this tremendous growth in knowledge that doesn't really translate yet into the clinic, but I think that there's lots of opportunity for people to have a compassionate discussion around this, and it's not a 0-1 world. It's not either no or yes.
Thank you for that. One topic I wanted to make sure we mention is bioidenticals versus traditional hormone replacement therapy. Dr. Berga. And we'll come to you after.
Okay. And so we actually can measure what the ovary does. We know the hormones that it made, and when they go away, we know when they went away. And so you may know that the treatment of diabetes has been revolutionized because we now have human insulin to provide, and we can give it with a continuous glucose monitor. That may be too much for some people to do, but it's actually available, and it actually helps with the treatment of diabetes. We now can do exactly what the ovary did with hormone replacement. It may not be for everyone. It may be more inconvenient, but there are options, and that is why, at least from my point of view, the bioidenticals have made their inroads, because people thought that that's what they were getting, and some of the time they may have been. So some of the bioidenticals are actually okay, and sometimes they cost less. So to the point of Dr. Rush, I mean, sometimes the industry hasn't been good to us in making things that are actually easy for us to take. So we've all, along the years, had to resort to actually having bioidenticals made by a compounding pharmacy, particularly in the early days of fertility. So it's really the devil in the details. You really have to know what you're doing. And there's a lot of hype out there, and there's a lot of people that will sell you something expensive. If it's expensive, I usually say there's something wrong. So be careful if it costs too much, because they're probably trying to sell you something you shouldn't be taking anyway. And then there are now, so I think that the revolution has started. It's really slow. I wish there was more money for this at the funding level, at NIH level. The woman who ran the Office of Research of Women's Health actually was my mentor. Her name was Vivian Penn. She was the first African American to go to my medical school, which is the University of Virginia. And she was my beaming light when I was a medical student. I just wanted to be like her when I grew up. And she ran that office for 20 years. She was the real, what I would say, pioneer in the field of women's health. We all, wish she could live forever. She's alive, but she's just a little older than some of us. But I really feel like if we could get this knowledge out, that would be great, but it's a lot to learn. If we could get you to question us, we would have to learn. So I say the role of medical students and patients is to question us and keep us honest and keep us learning, because there's so much to learn. And, without the prompt and without you asking us, we might somehow fall down a little. So I also sometimes say, and not everyone buys it, that nagging is a form of love. But I mean, if you ask hard questions and you don't get good answers, some of the time we will go and try to figure it out for you, and some of the time we'll come back. So I think it should be a conversation, right? It should be a partnership. It should be a dialogue. And if you don't have that with your physician, then probably you ought to be looking for someone with whom you can do that. And I know there's some great physicians in the audience today. I think we are all trying to be that person for you.
just wanted to find out, like, with the urinary incontinence, sometimes like laughing or whatever. Is there, like, at 57, I think I'm done. They keep telling me Kegels and stuff. I don't think I could tighten it anymore. But at this point, is there anything to help others, like they don't have to actually experience that, to keep it tight for them after they have their children?
Pelvic floor physical therapy. We don't have anyone here, but we do want to have other events like this where we specify different organ systems. So we'll have one related to that. But pelvic floor physical therapy, there, in the field of physical therapy, there are subspecialists who deal with issues of the pelvic floor, and they could work with you when you have conditions of incontinence. So you leak urine, or you have urgency, you have pelvic pain, you have pain with intercourse, you can't put a tampon or a pad in, a tampon in, because of pain. There are specialists who work just as how if you had a knee replacement and you needed to have therapy afterwards to help you recover, they could work with you with that. After childbirth, after pregnancy, not many insurances cover it, unfortunately, but you can also see a physical therapist. You don't have to have had a vaginal delivery. You could have had a cesarean section, and you could see a pelvic floor physical therapist afterwards. Part of it is aging, so you could do all those things, and you may sometimes still experience some leaking. But I would recommend that. Tightening is a tricky word for us gynecologists. Has very patriarchal origins. But when I think you're trying to say, you optimize the health of the pelvic floor so that you don't leak. Absolutely, that is out there. I wouldn't recommend just going around doing Kegels all willy-nilly, only because you could do the opposite, right? So you could have, you'll have those folks who go to the gym all the time and are really buff, but they can't extend their arm above here because they're so stiff and contracted. The same thing could happen with Kegels. So you really, again, want that professional guidance before you decide to undertake any specialized exercises.
Yes, Dr. Rush.
We added a little testosterone.
Yes.
And I know that can be,
right,
that you have to discuss that with your physician. And she was taking through a compounding pharmacy.
In Buffalo? A Buffalo
No,
one?
actually, I think it was out in Texas or something.
Yeah, I know that one.
Where she was getting shots of testosterone. I've never done that before.
Don't.
Thank you. Okay. So, because you can actually, I guess, the creams and the gels, but what approach do you take?
So androgens is the category, right? With the estrogens is a family, androgens is a family, and progestogens are a family. These are the three big families that the ovary and the adrenal gland make, and they are made in minuscule amounts, right? And so because of that, we have to think about what and when and how. And injections just never get you where you need to go, whether they're estrogen or progestin or anything else. So it got familiar because of Depo-Provera and certain other kinds of injections. So people got comfortable with the concept. But the concept is you get a big amount and it goes away. And a lot of times that makes it, even though it wouldn't be otherwise a drug of addiction, can make it a drug of addiction. And so for testosterone, it's we know from the gender affirming hormone therapy, a little too much sometimes has very profound effects, and some are not reversible. And so you're much more likely to get that with injections. So I would just say, please not. And then the rest of it is a long story.
Oh, but do you actually use any of the gels or the creams?
I really don't, because I am nervous that what we're giving them is actually going to cause more harm than good. And there's so much else to do first. And then I say, if you're not where you need to be, we'll talk about that and have another discussion. But let's try these steps first. And no one's ever come back yet.
I have to say that's been my experience also.
All right, well, it
But
must
we
be
do
right.
have other therapies out
I
there.
know. There's a lot of
that-
people in town doing it.
Right.
I know that. I know, and they come in and they talk to me, and I don't like to criticize other people, but I just for myself haven't found this to be the most necessary pathway.
Thank you.
I think we're going to field one more question. Go ahead.
First, I just want to thank you ladies for sharing this information. This is information I wish I would have had in my 50s instead of 70s.
Can I say I would never guess you were in your 70s?
I grew up. I grew up with a strong mother and grandmother in the house, and there's a myth. I think a societal myth of the strong black woman. I can only speak of my context instead of not a black woman who's strong, but quote unquote the strong black woman who is expected to bear certain things, take a licking and keep on ticking, and suffering becomes relative. Suffering means you're almost paralyzed and you can't move, So this information is so important for us to pass down to our children and grandchildren, because it carries over into the type of care we get, because that perception goes outside of us. It goes to our caregivers as well, and our professionals. We're expected to bear more pain. Our pain levels are higher, and so this is just so important to really get this information out there. My second thing is just sometimes my teeth feels like my teeth are hurting, and there's nothing wrong with my gums. I mean, I go for regular dental checkups, but sometimes it feels like my teeth are sore. And if that makes sense, I mean, it sounds crazy, but is that somehow related to hormones?
May I speak to her first point? One of the things I've learned, and I've shared that I have mental health conditions. I have spent time in a psychiatric institution. And what I learned in that space is black don't crack. It shatters into a million pieces. And so we have to, and I also used to say, my ancestors were slaves, so I know that I can handle this. But what I am not is a slave. I had to lose everything in order to get to the point of understanding what self-care is. Mm-hmm. And we have to be able to have this kind of conversation, mm-hmm. right? So that we can do better for our children and our children's children. Our parents and grandparents and great-great-grandparents and great-great-great-great-great-great-grandparents had to live to survive. And while a lot of that is still true today when we look at racism and how we function, there is still a fullness that we can bring to the table to ensure that we are seen and heard always. One of those things, and I mention this especially when there's other folks from other backgrounds in the room, because until recently, the hair that grows out of our head was illegal to have in a workplace if the workplace decided you could not have the hair that grows out of your head. That is America. And so while we have these laws and rules that say you cannot discriminate, you also cannot show up as yourself. I speak very differently in these spaces, and then y'all saw other Kelly when I was telling you how we have to we have to show up and not drop the consonants, right? And I used to get in trouble with my grandmother for saying 50 in bread instead of 50 in bread. I got in fights for being too white. At 9, I was named Aquila, wisdom, one who thinks before she speaks. I am the red, the black, and the green. So what I am not is too white. But I had to fight, just like many of us had to fight and still have to fight to be able to show up and be seen as themselves. I cannot tell you, my white friends in the room, how many times I've walked into a room and people say, "Oh, you're Kelly? You're not what I was expecting." Because my name Kelly Wofford and it's not something, right? And so as long as we are fearful, and that is what it is, fearful for our families, for ourselves, for being able to maintain a job, to keep a job, and living in fear of losing that job, for showing up as ourselves. And that is inclusive of the doctors in the room. It is all of us. It is a part of the struggle and ownership of owning our Black skin. We have to break that cycle of being too strong. And yes, I could do it, but I'm not. But I had to almost die to get to that. Like, I had to say goodbye to this world in order to take care of myself. So what I won't do is what I'm not going to do. And I said what I said. But I had to risk losing it all. Every time I do that, I risk losing it all. But I'm willing to walk out my house with a knapsack on my back if that means my mind and my body is free. They could take the house, they could take the car, they could take the job, they could take these nails, they could take. I don't need it if that means I have to show up truly as somebody else. And so for those of us that can show up in that space, and I told you about my primary care physician, she in her career had to get to the point of safety to be able to spend an hour with a patient if that's what she needs to do. Our new doctors are not, they need to be able to keep their jobs. They need to be able to come the medical director of, they need to be able to come the directors of, and the owners of. And so for those of us that can flip over a table and not give a, then that's what we need to do, because some of us cannot yet because of where they are in their journey. And so some of this hurting and sweating and bleeding and crying and literally dying because we're Black women and not heard has to stop. But we'll only stop, one, when we start speaking up, and two, y'all start speaking up. It is beyond, we cannot, so this one it has everything to do with women's health. I'm sorry, Doc. If we just look at pay disparities, women make less than men. White women make more than all the other women, except Asian women. Not all Asian women, because Indian women are Asian women, right? Like, not all Asian women, but specifically Chinese women. The rest of the Asian women making money not like the white women. And so when we talk about pay disparity and white women say, we want equal pay, well, I want equal pay to you. And so if my struggle is not a part of your struggle, then we're never going to get anywhere. So we have to show up in all the places and in all the spaces, because I need you as a physician or researcher or HR manager, like whatever your job is, to know that when you show up and fight for you, 1, 2, 3, 4, 5, 6, 7, 8, you have to be inclusive of fighting for me, of fighting for her, you know what I'm saying? You have to. Otherwise, you're only working to secure the futures of white women. And if I'm not knocking that. Like, if that's what you want, then stand on that. Be like, I'm only here for the other white women, because that will tell me where I need to go. Right? It is what it is. And so if you're not only here for the other white women, that means you have to speak up and say the words that are difficult to say, not just in these spaces where it's expected, but in your homes, at your little parties, like the backyard get together, you know what I'm saying, with Uncle Joe, who's always been a racist. Well, perhaps somebody need to say something to Uncle Joe. because he has an impact on your children, and you don't even realize Uncle Joe is planting seeds in them kids, so that when they grow up, you're like, well, I don't know why Timmy came out like that. It was Uncle Joe. But not only was it Uncle Joe, it was you, because you didn't say nothing to Uncle Joe. All of that connects to women's health. All of it. My health and your health. If I'm not healthy, you're not healthy. And if you're not healthy, we dead. So we this is a us issue. And it's okay to say that this is a us issue and define who us is. Because if us ain't us, then it is a you thing, not a us thing.
Thanks, Kelly. And I think that is where we end today. Thank you all so very much for your presence, for your questions. I know we didn't get to answer every single one of them, but as we said, this is the first of many. We are keeping these index cards to figure out topics for our future events. If you do have another topic you'd like us to talk about, you still have an index card, write it down, pass it over, or come up to me and let me know, because again, we want this to be led by you, by your concerns, so we could address and advance women's health in Buffalo. I want to give special thanks to Jamil Cruz, he is founder, owner, CEO, master extraordinaire, father of a very cute baby that I delivered. Cruise Control Media. Thank you, Jamil. I appreciate you so much. And I have to acknowledge Dr. Fred Archer here, the other man in the room. Thank you for being here and for supporting our efforts always. See you all next time, and thank you again. Hope this was helpful.